Good evening, all of you. Today we are on to the 14th edition of the Ophthalmology PG classroom. And this time we are having a continuation of the Retina spotters. So today we were trying to discuss diabetic macular edema. And for discussing diabetic macular edema, we have none other than the doyen of Retina, Dr. Dinesh Talwar from Delhi, my own teacher, and an expert in analyzing all the clinical trials in ophthalmology. So we will go to the presentation, and through the presentation, we will have some case scenarios. And from the case scenarios, we will look at possible solutions to those case scenarios and how we can use clinical trials to come into clinical decision making in each of these situations. All right, so let us start the presentation. Can you see the presentation now? Is it visible to all?
Yeah, go ahead.
Okay. So here is a case of a patient with moderate to severe non-proliferative diabetic retinopathy with hard exudates which are slightly away from the fovea, but not actually involving the fovea in the right eye as well as in the left eye. Vision is both eyes 6/6. And that's a fluorescent angiography finding, which shows it's a early frame, which is showing some microaneurysms. Probably in the late phases, there would be some leakage, which is causing by the leaking microaneurysms. And these are cases in which, maybe before 2004, we used to have only the fluorescent angiography, no OCT. And currently what we would do is we would do an OCT to actually pick up if there's a center involving macular edema. And this is a point of time where there was no OCT, and this was a fluorescent, and this was the clinical picture. And as you know, we had the ETDRS definition of diabetic macular edema, as there were three criteria. There were hard exudates within 500 microns, hard exudates with thickening within 500 microns, and area of hard exudates or thickening about one disc area, which is...
Can we go through that again? Because this is critical for them to know.
Yeah. Let me stop sharing the presentation, sir.
No, let the presentation stay there.
Sure. Okay.
First of all, I mean, you don't mind if we stop?
Absolutely. I mind if you don't interrupt me.
See, first of all, yeah. So since we are doing image based on fundus photography, so will any of them interact? I mean,
sure.
What are the features of beginning? May Dr. Gopal said severe or moderate to severe NPDR. What are the features of that in these photographs? Are there any photographs, pictures of that? See, he knows more than what he's showing you. So there's a difference here. So the question is, based on this photograph, was he trying to trick you into something?
That I always do, no?
Yeah. So it's a little tricky. So you have to say, in the photograph, can you see any evidence of severe NPDR? Anybody?
Can you actually define severe NPDR based on this single photograph? In other words?
Yes. So I think we discussed this in our
we discussed that last time actually. So severe and very severe, the definition would be based on 3-to-1 rule, right? So can somebody tell us the 3-to-1 rule, Netra?
Okay, so the basic point is that actually you can't call this severe NPDR on this photograph. You're saying NPDR, but you can't say which grade of NPDR. So this is number one. See, you should be very careful. Actually, he's seen the whole fundus. He knows this patient had a moderately severe or severe NPDR. So he could make that comment. But can you make that comment based on this photograph? And this is a problem we have very often, because based on this photograph, you can't comment on it. Okay, so this was number one. The second thing was, one more thing which you said towards the end. The definition of ETDRS, diabetic
macular edema.
Clinically significant diabetic macular edema, which is the most severe form. They've actually divided it into three forms, three grades of severity. Which is the most severe grade? Would anybody like to tell?
So CSME can be defined as retinal thickening at or within 500 microns, or
the first one is not on and within. The first one is within, involving the center. The most severe form is center involved, is retinal thickening involving the central fiber.
center. Yes.
Okay.
Then second one is hard exudates at or within the 500 microns of the center of the macula with adjacent retinal thickening.
Yes. And the
third one is the retinal thickening greater than or equal to 1 disc diameter in size.
No, 1 disc area in size.
1 disc area in
There's
size,
a lot of difference between 1 disc area. What is the difference between 1 disc area and 1 disc diameter? Is there any difference between the two? If I say 1 disc diameter, if I say 1 disc area, is there a difference? Do the calculation. Pi r square.
1 disc diameter can be vertically oval, it can be horizontally oval.
Pi r square is what? Pi r diameter, 1 diameter, 1 diameter into squares 1, that's pi r square. 1 disc area, okay, diameter is 2r. So r is equal to half the diameter.
Half the diameter.
So if half the diameter into half the diameter is equal to 1/4.
1/4 of
pi r square 4. So you understand the difference? 1 disc area. Okay.
Yes, sir.
1 disc area. Now that is pi r square. Right? But if it's a disc, then it's equal to 2 diameter, 2 radius. That becomes 4 times. So it's a huge area compared to a disc diameter area is 4 times. 1 disc area is 4 times 1 disc area. 1 disc diameter is very big. Okay?
Yes, sir.
Is that clear?
Yes, sir.
Okay. So it's an area which is 1 disc area in size, but within 1 disc diameter of the foveal center.
Yes.
Okay.
Yes.
The importance of this is that this level of macular edema, this is clinically significant macular edema, but it's compatible with 6/6 vision. Okay.
Yes, sir.
This is the mildest form.
Yeah, this is the mildest form. Yeah.
And this is what we are showing in this picture.
So sorry, I had to stop it in the middle. Can we go back? I said sorry. I mean, interrupting like that.
No. It's okay. It's okay. It's okay. So here, what are the studies that basically, what should be done? So basically, here what we are basically going to do is.
Okay. Again, is the right and left require the same treatment?
So we have an OCT. There's a very mild macular edema. Oops, sorry. Yeah.
See, let's take one eye at a time.
Sure.
You can take the right first, then we can come to the left. Or either way. Whoever wants to speak.
Lisa, can you speak now? Lisa is not there. Riyesh is there? No, Lisa is there. Yeah. Right eye. No, you're muted. You muted. Yeah.
Yes, sir. So the right eye is showing moderate NPDR with diabetic macular edema with a minimal edema on the OCT. So based on the treatment, we can go through different trials. We have different clinical trials based upon the ETDRS study. It was to compare whether the laser or the injection was giving the intravitreal.
ETDRS had no injections.
Sorry,
ETDRS is in 1980s. No injections. ETDRS was about a focal macular laser.
Focal macular laser and the aspirin. It was about the aspirin.
Relevant at the moment, no?
Yeah. So let's not go into the trial now. Right now, let us talk about how will you treat.
How would you like to treat this patient?
Yeah.
I would go with the intravitreal injection, sir.
What is the vision of the patient?
Vision of the patient is 6/6 in the right eye, 6/6 in the left eye.
Yeah.
So what was the inclusion criteria of most of the trials for injections in terms of vision? Was it 20/20 or 20/25 or 20/30 or 20/32? What is the visual acuity criteria?
20 by 60, sir.
No.
No. Okay, so it's 20/32, and it goes up to from 20/32 to 20/320. Okay. Most studies have that, except for a few where we'll talk later on. But now tell me, what does 20/32 mean? What is that vision equal to? वो तो उन्होंने अपने उसमें दे दिया ना?
Yeah.
What does 20/32 mean?
20/30 is what vision? 20/30, 32. 20/20 is 6/6, no?
6/6.
Yeah. 20/25 or 20/30 is what?
6/12.
Okay. Yeah, 6/9.
6/9.
Yeah.
Okay. So this is, it doesn't come under the category of that trial. So now it doesn't fit in with the trial. According to the trials, you don't treat patients at 6/6. Okay.
According to the injection trials.
Yeah, injection trials. Is there any trial which comes closer to that? Closer to 6/9? ठीक है. ठीक है.
Rice and right trial, sir.
No, Rice and Ride also the inclusion criteria was about. So in ETDRS trial, actually visual acuity did not matter. It was a clinically significant macular edema definition which mattered.
Yeah. So, but any injection trial which went closer than 6/9, where they gave
Patient's vision was also better, and then they took it to the trial and saw what happened.
They did give injection, or they had an alternate. Okay, so all the other trials except the one we're talking about, that's called Protocol V, is a trial where 6/7.5 was taken as the vision criteria. Okay. So even if you take that as your criteria, let's assume for a moment the vision was 6/7.5 just for a moment. Then what would you do? Am I audible?
Yes, sir. Yes, sir.
Effectively the question becomes, what did the trial show, and based on that, in this situation, what are the alternatives for you? Anybody aware of the Protocol V?
Yes, sir.
Now, go ahead.
Whether basically in moderate to severe NPDR, the aflibercept can decrease the.
So it's not moderate to. It was nothing to do with NPDR. It had to do with diabetic
macular, center involving diabetic macular edema.
Okay.
Okay.
You understand? So it's nothing to do with NPDR. Okay.
It did not have anything to do with the grade of retinopathy, is what Sir is meaning. It had, center involving diabetic macular edema in Protocol V. when like in all the other trials, we will take vision less than 6/9 or less than 6/9 as an inclusion criteria for injections. Here they looked at whether with the better visual acuity, if we treated,
6/7.5 was their cutoff. So their cutoff was 6.755. So we are taking 6/7.5 because 6 meters, everything will go out.
So they planned observe the eyes with center involving diabetic macular edema with a baseline, with a good baseline vision of 6/9 or better.
Okay. Did they compare it with something, or was that it was only an observational trial?
Compared with the injection? Did they compare observation versus injection?
Or laser?
With the injection, they compared.
Okay. Which injection? See, it's important because the injection should be one which is effective, no, very effective. So which injection? Okay, which injection do you consider?
Ranibizumab.
Which do you consider the most? Yeah, Eylea. So they compared injection Eylea, PRN, with observation, as you said, and with something else. Which is the other modality you can use? बहुत कुछ तो है ही नहीं. We don't have. Huh? Yeah, go ahead. Someone said something.
Yes, you are telling something.
Laser photocoagulation.
Yes. So with
laser photocoagulation.
Laser. So they compared all these three modalities. So what did they find? Was it like, what was the outcome? Should we go ahead and then give injection now for this patient? This is a very important case because, in fact,
at the end of 2 years, there was no much comparative difference between all three groups.
Perfect. So there was only, actually, if you want to know, it's just 1% difference.
No, and what was the median visual acuity across the three groups? It was very good. It was almost 6/6.
No change.
In all the three groups.
75% of the patients in the laser group and 2/3 of the patients in the observational group did not need any kind of intervention. So that means if you don't touch these patients, chances are at least 2/3 of your patients would need nothing. So is it worth giving injections when for 2 years nothing is going to happen?
Okay.
So now with this information with you, would you like to give aflibercept to this patient? Yes or no? To bol do yaar.
Not required, sir.
Yeah, not required. Okay.
Aflibercept or ranibizumab, nothing is required at this point of time.
Nothing is
but
needed.
There is one more catch in that, sir.
Yeah,
I want to tell you that the OCT criteria for inclusion into the trial was, 250 microns.
Yes.
Not even 300 microns. That was another catch.
250 or less, or 250 or more?
250 or more.
Yes. So it was very early, like you have. It was the exact case which you showed.
Yeah.
But now, is there anything in there, any other study which can tell us something else that's worth doing? Same patient, right eye.
Hard exudates, away from the fovea, one disc area.
Is there any, macular edema hai ki nahi hai? Is there macular edema? Is it
clinically significant macular edema?
Is there non-center involving macular edema? But it is still clinically significant.
Okay, this is the macular edema, which is about one disc area. This is one disc area. This is more than one disc area in size. Is it any part of it is lying within the one disc diameter center of the fovea?
Yes, sir.
Is it not? Yes.
Yes, sir. Yes, sir.
So that is why. Yeah, sir.
Yeah, actually, you have. I can't show my pointer. You see the very dense hard exudate, and you go temporal to that above. There is macular edema there also. Yeah, just below the surface.
This much area is macular edema.
Yeah. So this whole thing is. So part of it does come into the category of non-center involving diabetic macular edema, which is clinically significant because a very large area of edema. right? Now tell me something. Yeah. So, okay. So he already told you what to do. So it could have been taken up for focal macular laser, right? And is there any study on that? Is there any study for focal macular laser for non-center involving diabetic macular edema?
ETDR study was on the focal macular laser.
Yeah, but there is also a recent study on the same from the DRCR net group. So I'm just telling you that it's not just old information available; you have new information also available, and it showed that it was vision was no different between the two groups, but the edema, central edema, got reduced a little bit. Okay, so now go ahead, Gopal. So what happened?
Yeah. So
Incidentally, the
that
same
particular
thing in the other eye
patient.
also. Same thing is there in the other eye also.
Yeah. 1 second, sir. Yeah.
Yeah. You can see जहाँ laser किया ना वो edema खत्म हो गया. Right? Yes. Even though on the left side microaneurysm is still there, but most of the edema has gone away.
So at this point of time, sir, let me just ask them, how is a good focal macular laser done? What are the how it should be done? Nia, can you attempt? How is a good focal macular laser? And you are muted, my dear.
Done to the leaking microaneurysms.
Yeah. How far from the center of the fovea? You leave a little central area.
What is the minimum area you like to leave? But incidentally, यहाँ पे तो उससे बहुत ज़्यादा है. But how much would you like to leave?
500 microns away from.
Yeah,
Yes.
500 is the absolute limit.
350.
In this case, incidentally, I think 1 disc diameter was left. Okay. What else? How much? How do you decide how much? What size? What power?
It should be of 50 micron spot size, sir, and it should be done at a duration of about 0.1 seconds. Duration of 0.1 seconds, and it should be done to the leaking microaneurysms, and it should
Grade
be
of burn?
Grade of burn should be grade 2.
Okay.
Grade 2.
How many burn widths apart should we hit?
Half burn width.
Here you
One burn with apart.
no, 1 second. You're not doing a grid. We're talking of focal macular.
Focal macular only.
It's a direct laser to the microaneurysm.
Leaking microaneurysms.
Okay. Supposing you were doing a grid, I don't appreciate doing a grid, but supposing you were doing a grid, how much is the space you would leave between burns? Just because you may be asked such a question in the exams, you should know, but it is not, grids are not something which is recommended nowadays. Supposing I want to leave a half burn diameter space between 2 burns, how much should I leave the burn when I laser? How much space should I leave when I do the laser? Is there any difference? Or is it just unnecessarily trying to trick you? I want to laser. Is there any difference between the laser size when you laser and say 5 minutes later?
Yeah.
What happens?
Yes, so, there will be whitening of that area.
There'll be, yeah. Now when I laser, there was a whitening. Now what happens if I see the same area 5 minutes later?
There will be some peripheral runoff.
Yes, so there will be a peripheral runoff. So if I want to leave, say, one burn diameter space between two burns, no, one here, one here. So when I laser, how much? Now I want one later, not one just now.
Okay.
So how much should I do just now? Basically,
More than one.
you need
1.5 burn size.
around 2 burn diameter. Ideally, you should leave 2 burn diameter at that point so that you end up with 1. If you're doing a PRP, you leave 1 burn diameter.
Okay.
Because you ultimately want half in between them. Okay, approximately. So 1.5 to 2 is what you need. 2 is absolutely okay. You want to be safer in the macula. But now, this is only in case somebody says there is an area of diffuse. When do you do a grid? When would you consider a grid?
Yeah, Gargi, can you take that question? So we have talked about focal macular laser, which is directly to the leaking microaneurysm, only to the leaking microaneurysms. Now we have the other thing, which is called a grid laser, or otherwise called modified grid laser. So what would be the indication of a grid, and how would you do a grid? You're muted.
So again and again, I'm telling you, we don't recommend it nowadays. It's not
modified grid, sir.
Even modified grid, because a grid causes a decrease in vision.
Sure. Yeah.
And I'm going to ask for somebody to tell me if there's any proof available. Never accept anything without evidence. Not even from anybody who claims to be your teacher.
Yeah, Gargi. So what is a grid laser?
Yeah.
Sir, it's a laser done in the macular region in the C-shaped size, which is a modified grid laser.
So what is it done for?
Sir, for leaking microaneurysms.
No, for leaking microaneurysm, you're doing focal laser. I see a leaking microaneurysm. I hit that laser at that area. Why will I do a grid for that? When would I do a grid? But I know it's a little tricky part. We'll discuss that later on. We'll come to that. You've been unnecessarily brought into this area, but since this is part of your teaching, we'll discuss it.
So grid laser is usually done in all areas with edema, but not because of microaneurysms.
So what is it called?
Diffuse leakage.
Diffuse
Diffuse
macular
leakage.
edema. So if it's diffuse macular edema, that means not. So then you do the grid, right? Now, when you do the grid, is there any difference? Like, I think that's what Gopal was going to ask you when he was asking space between the burns and all.
Yes, sir. So when there is diffuse macular edema or macular edema away from the areas of leaking microaneurysms, which now we can easily pick up on an OCT. We can pick up an OCT map and we can say that, okay, this is a leaking microaneurysm, but edema is here also. So those areas, currently, we may inject if it is involving the center of the fovea. But if it is away from that area, away from the microaneurysm, then you can
Yeah, so that's not a modified C grid. That is only a grid in that area. That's not a modified C grid. That I think we need to clarify to them. So you can do a small grid in an area where there is no microaneurysm, but there's edema, and which is further away. So you say, okay, let's do a grid.
Further away from the center of the fovea.
From the center of the fovea. So now, how would you do? What is the spacing in that? I think we've given you the answer actually almost. Didn't we give the answer?
Yeah, it's about one burn width apart. And you told them that in order to get a one burn width apart, you should actually put it at 2 burn widths. And the burn width is like, now we are using 50 to 100 micron burn size.
Yeah.
Probably a 50.
Yeah.
Okay. So that's what it is.
What about this? Now in a grade, what is the maximum grade you will go to? In a focal, you may go even up to 3, but what is the usual picture of the burn in a grade? What is the upper limit of that?
Grade 2.
Grade 2 light gray, barely
So it's
visible
grade
burn.
2 or just visible. So you can be 1 to 2. You don't want to have intense burns in a grade.
Do you know why so? Basically because, giving a lot of energy into, see, basically this is to tickle the retinal pigment epithelium to, resolve or to absorb the fluid. But if you increase the size of the burn, obviously the damage is going to be more. The contrast sensitivity as picked up would be lesser. If you do a microperimetry or something like that, you will get a lot of areas where visibility would be gone. So your scotoma will increase. So that is also, again, it's not just about central visual acuity. It's a whole macular function that you have to look at.
So it'll become degenerative rather than tickling. It's no longer just tickling the RP. It will actually become a degenerative area.
Yeah. Should we move on, sir, to the next case?
Go ahead.
Sure. So this was like, I was basically asking injection or laser, how to decide role of laser and prompt laser versus this deferred laser. That will come to in the next slide. So here is a case with a central hard X-ray with cataract with a vision of 6/12, not much macular edema though. Okay, and no retinal thickening on OCT. All right.
Here you can see moderate NPDR.
Yeah.
Here if you see, you can in this right eye, you can say yes, there is moderate NPDR. You can see there are
1, 2. Okay, something
enough to postulate that there would be reasonable number.
Yeah. Okay. So here is a case with cataract, no retinal thickening on OCT.
There are 2 patients, 1 patient.
No, this is the left eye, little more magnified picture, sir. The right,
okay,
so this is the right eye.
Yeah.
Okay. So can we proceed with cataract surgery, or is OCT needed? If edema is there, how to proceed? That's the question here. So the presence of, there will be a lot of patients with diabetics with cataract, and there will be some hard exudates near the fovea, etc. So how will you proceed? And you are going to do a cataract surgery. Yeah. Can Yash answer that? Do we require an OCT?
Always keep in mind, you want to be beaten up, you don't want to be beaten up. Right?
No, sir. If I'm seeing hard exudate through a cataractous lens and I have a doubt about it, I should get an OCT done. Especially in a patient with the diabetes history and the fundus looking like
I would go further than that. If you have a diabetic, even if you can't see and if you can see the fundus, grossly, get an OCT done. You can miss out macular edema. Hard exudates may not be there. They may be there, they may not be there. Here you're lucky they're there, you can have a look at it. And why is it important? You don't want to do the surgery in a patient who already has macular edema.
Post-operative edema will increase.
Edema could increase. And second thing, it's possible the edema was not because of cataract. The fact that you could see through it, maybe it was cortical cataract not interfering his vision, interfering with your ability to see clearly. Now, when you operate, the edema doesn't go away, vision doesn't improve, so you get beaten up now. Sometimes. Right? So, OCT, first question, OCT. OCT must be done. If you can see, it's ideal to do an OCT before doing surgery. Okay?
Yes, sir.
Am I being overly aggressive?
That was that. And then we were looking at, can we proceed with, see, if there is OCT has edema, if edema is there, how to proceed? Definitely we should inject, we should reduce the edema and then proceed. Okay.
In fact, you should see
any cutoff for.
You should give the injection, see after the first injection whether the patient's vision is improving. I've had patients whose vision improved so much, they said, I don't need a cataract. So sometimes that may happen. But the second thing is you give the first injection, especially if there's a lot of edema and you see the response. And if you see OCT response, not a vision response, then after the second injection, you can go ahead and do the surgery. That way, you're sure that you brought down the edema to the minimum And then now you've given the injection, and then you can follow up and subsequently, and you can tell the patient that you may need injections later on. It's very important to tell such a patient that this is not going to be the end of your story. Cataract surgery is not going to end everything. You will need treatment for, and if you tell him before, he won't catch you as the reason. He said, no, you told me vision will improve. So you have to tell him that you may need injections. Okay.
Sir, any cutoff for this? Like how much of edema would we try to inject? Or if it is very subtle, very minimal edema, should we inject first and then operate?
The surgery. If it's little bit, you give the injection and do the surgery. If it is very much, say more than 300, 350 micron, you give the injection, see the response first.
Okay.
Then give the second injection and do the surgery.
Yes, the basic thing is, it all depends upon how much is the decrease of vision due to cataract and how much is the degree of macular edema. Like sir said, if the macular edema is very less, okay, you give one injection, macular edema is gone. Now you have the cataract, which is significant. Definitely go for the surgery. Okay, but if the cataract is also very mild and macular edema was there, there's a vision drop to 6/9. You gave one injection, vision improved to 6/6. The patient will say, "No, I don't require a cataract surgery." That is the one situation sir said. Now the third situation is macular edema is huge, 500 microns, 400 microns, something like that, and cataract is also not so much. So then that is a point of time where you keep injecting till the edema is significantly reduced, and then only move into a cataract surgery situation.
Don't be
in the fourth situation. Yeah, sir.
Yeah. Don't be in a hurry to do the cataract surgery.
Yeah, if the cataract is mild.
Unless the cataract is also very significant, then after maybe 1 or 2 injections, you can consider. I say, look, you've got cataract and diabetic macular edema. Both have to be managed concomitantly for a long time. Now we brought the edema down to a stable level. We're doing the cataract surgery, and you will need injections again after that. It's important to tell that to the patient, because otherwise his expectation is cataract, and that's the end of the story.
Okay. So there are these 4 situations, depending upon the macular edema, which is mild or more, or cataract, which is mild or more. So depending on that, you have to pick and choose whether you need to completely reduce the macular edema before surgery, or you have to basically, start treatment, then get the cataract surgery, and then move on with injections.
I'll add a rider there. I never say completely remove the macular edema, because that's almost impossible to do when there's macular edema is severe. You stabilize the macular edema. You've given the first injection, second injection, third injection. This se zyada nahi hoga. Now you go ahead and do your cataract surgery, and then you follow up afterwards. You may even decide, if you didn't get a good response to the first 2 injections of anti-VEGF, you may want to give Ozurdex and say, then we'll do the cataract surgery.
Okay, sir. So this is a case in which a post-cataract surgery.
There's one stage situation you didn't discuss, which was the more tricky one.
Which one was it, sir?
One which you actually showed. No macular edema and cataract.
Yeah.
Okay. So I don't believe, there could be a difference in opinion, but I don't believe in giving anti-VEGF agents as a prophylaxis for cataract surgery. It's not a prophylaxis. If it comes, we will treat it. If there is no edema, we will not give an injection before the surgery.
Yeah. Okay.
But you can give Nepafenac. That is a good drug for prophylaxis for post-operative CME in patients who have diabetes.
Yeah. A combination of a steroid plus a Nepafenac or a
bromfenac. Continue that later on. Continue that for at least 6 to 8 weeks later.
So here is a patient who had a post-cataract surgery. You should understand that if you are not treating a diabetic macular edema, cataract surgery can actually worsen the diabetic macular edema and also can worsen the grade of diabetic retinopathy. Here's one case, pre-cataract surgery, fluorescein angiography is this. Post-cataract surgery, you can see that in 3 months, there's significant worsening of the diabetic macular edema, and you can see now that there is a neovascularization, the disc which is coming. Okay, so worsening of diabetic macular edema occurs, 1, because of a release of a lot of cytokines, number 2, PVD induction or endophthalmodonesis, and all this will actually worsen the diabetic macular edema. So any patient with diabetes with a little bit of edema also, if they're undergoing a cataract surgery, please keep on following them up and see if it is worsening and treat them early. Sir.
Yeah. So tell me, how do you think this patient was managed and what improvement should be done? Would you have done if you were in this place? How do you think this patient was managed? Did this patient get anti-VEGFs before cataract surgery?
Now, this patient did not receive any anti-VEGF before cataract
Did
surgery.
he get anti-VEGFs after surgery?
Yeah, did not get anti-VEGFs after surgery.
Yeah. So you see, so here, this is like, in a small way, this is like negligence. Because we know that these patients will worsen after surgery. So what did he need? He needed, at the minimum, follow-up after surgery on a regular basis, every 4 weeks. And when you got the first evidence that the edema is increasing, he needed to be given anti-VEGF treatment. Actually, he had enough edema that he needed an anti-VEGF before doing the cataract surgery. Go back to the picture again. Do you think he had cataract at all?
Sir, that discussion we'll have later, sir.
No. The point I'm trying to make is, it's important when you get so much edema to decide whether this patient has cataract or not, responsible for that vision loss.
Correct.
The problem that happens is that this is a mistaken diagnosis. The diagnosis was diabetic macular edema with, and I can tell you what this must have been. This must have been cortical cataract. So
you can see the haziness here.
Yeah. So basically what happened was, when you see any opacities, they need to be removed according to anterior segment surgeons. So basically got a cataract surgery done. But actually the vision problem was because of the diabetic macular edema. So the important thing is, in this patient, what we discussed before, the patient needed an anti-VEGF agent before surgery, if at all, and then subsequent follow-up. So that's why that was the point I was trying to make. That the cause, see, every patient is a story. You have to build that story. The story says, the patient comes with a story says, I have vision loss. Now you have to say, okay, what is this story? Why did this vision loss occur? Is it because of diabetes? Is it because of cataract? Is it because of macular edema? Is it possible something else happened? So 660, is it possible patient got, if this was the initial picture, you could even say, is it possible the patient has AION? There could be a lot of things. I'm not saying this patient has AION. I'm just saying that lots of things need to be looked into. You must be sure of that you've created your story and it explains, the findings explain the story. Then you can do a good management. Okay, use that in every case, whatever the disease. DME is just one this thing. In every disease, every case, every patient is a story. Build the story. And every component of the patient's findings should fit that story. Then you will be on the right track. So here, I see cataract not being significant. I see macular edema, which can explain 612 vision. And the patient needed anti-VEGF treatment. Okay, go ahead. Anything you want to?
No, sir. How it is different from cataract without diabetic macular edema? So as sir said, depending upon the amount of diabetic macular edema, we may need to inject, etc. Follow-ups, frequent follow-ups should be there for. Many times what happens is after cataract surgery, after the first week follow-up, you give glasses and ask the patient to come back after 6 months. That is not right in a diabetic macular edema or even a diabetic retinopathy. You should follow up the patient a little more frequently to see if it is coming. We may require serial OCTs and may require repeat injections and laser. And cataract surgery worsens the diabetic macular edema. Let us come to another situation, sir. Multiple central leaks, spongy edema on OCT, 550 microns. There is a cataract. Now, this is a case in which there is a significant diabetic macular edema, not like an early case where there was a little bit of macular edema. Here is a case where there is significant diabetic macular edema, a lot of micronerism, a lot of hard exudates, vision is 6/36. There is possibly a bit of cataract as well. So how to proceed? Do we require to inject laser? Which injection? Prompt laser versus delayed laser? These are the questions. So this question will probably answered. If the diabetic macular edema is significant, probably we will be required to inject maybe once, maybe twice, see that the diabetic macular edema is stabilized or minimized, and then proceed with cataract surgery. Now, sir, any take on which injection to take? IVA, IVTA, intravitreal?
Now let's go by evidence-based medicine.
Sure.
Okay. Based on pure evidence available. I'm talking on level 1 evidence. What is the information you have over here? What was the vision of the patient? Sorry, Gopal, I don't remember.
636.
636 was the vision of the patient. Yeah. Okay. Is that enough to make a decision?
OCT is needed.
OCT 500.
OCT?
550 microns.
550 microns. Now, do we have enough information? Okay. You have to say no cataract as a cause of the vision loss. You could have 636 vision because of cataract, not because of. So you're saying cataract not explaining the vision loss. Yes, no.
Yes, sir.
Okay. Okay. So now, what is the evidence? According to the evidence, what drug should I use? Forget about costs. What are the drugs available to me? Just list the drugs.
Bevacizumab, aflibercept.
Ranibizumab.
Good. Bevacizumab, aflibercept, ranibizumab, then triamcinolone, yeah, dexamethasone implant.
Yeah.
Okay. Ozurdex.
So now tell me, based on the evidence, what is the drug of choice in this situation? Then we'll discuss what evidence. Come along, let's be quick. We won't be able to finish this thing. Say anything, yeah. How does it matter? Jada se jada gal to you have a 33% chance of being right.
Yeah. So, Gargi, why did you say aflibercept?
What is the evidence? Just like that. Just what is the evidence? What is the evidence that says aflibercept is the best drug?
Sir, according to protocol T, aflibercept has letter improvement better than others.
Yes, so perfect. So according to protocol T, in patients with a visual acuity of less than 615, okay?
Sir, I think you should just explain protocol T at this point of time.
Okay, so protocol T evaluated 3 drugs. They evaluated aflibercept, they have evaluated ranibizumab, and they evaluated bevacizumab. So it's the best protocol we have for deciding which drug to give, right? And they gave the drugs, they didn't call them loading dose, they gave them monthly, and they continued to give the drugs for the first 6 months, as long as the patient was improving or deteriorating, both ways. So every 4 weeks, the patient got an injection if he was improving or deteriorating. After 6 months, the patient was given rescue laser if it had got a deterioration. So first 6 months, they would more or less all the patients would get an injection every month, unless they became what? Unless they became normal foveal contour with a 6/6 vision. So if they reached that end point, then they didn't get any more injections. Now, what did they find? They found that in patients who had vision of less than 612, right? Those patients, aflibercept did a better job of getting visual outcomes than ranibizumab and bevacizumab. Okay. Now, this difference. Now, the worse the initial visual acuity, the worse the baseline visual acuity, the better the more aflibercept scored over the other 2 drugs. Clear? So if you are at 612, you're still borderline. If you're at 636, aflibercept seems to have a better result than giving the other two drugs. But it's a little more complicated than that. We'll come to that later. But this is the basic outline, that if the vision is less than 612, say 615 or worse, the drug of choice becomes aflibercept. Okay? There's more to it. If the patients, in these patients who have a visual acuity, whose baseline visual acuity is less than 612, those with a macular thickness, a central subfield thickness of more than 400 micron, were significantly better with aflibercept. The outcome was significantly better with aflibercept than with ranibizumab and with bevacizumab. Okay, this is the other important thing. If the thickness was between 250 micron to 399 micron, the outcome difference was not too much different between aflibercept and ranibizumab. So this you remember. So even within that group, so supposing now you want to do this fine tuning, then if the vision was less than 612, like in this patient, 636, but supposing the thickening was say 350, you had a choice of both aflibercept and ranibizumab. But here we have a thickening of 550. So there is only one alternative, aflibercept. Okay, so that is why both these things are important for deciding the treatment. Okay, this is important because costs can vary because of depending on the drug you choose. Okay.
Now there is one more thing. These looked at 3 anti-VEGF agents.
Yeah.
It did not include long-acting Ozurdex.
Yeah.
Ozurdex was not involved in this.
Yeah. So
Many
now
people-
that is true. Now, whenever you do any treatment, in principle, you have to take the treatment, which is what all will you consider? You see efficacy, you see safety, and you see cost. 3 things you have to keep in mind. Okay. Now I'm going to ask you people, what is the most important thing for you? Is it the efficacy? Is it the cost? Or is it the safety? This is a philosophical question. You can answer whatever you want, yeah. But-
Efficacy.
Huh? What?
Lisa wants efficacy.
Elisa.
Somebody wants safety. Somebody else, yeah. Who wants safety?
Safety.
Yeah,
Who
Mia
wanted
wants
it?
safety.
Who wanted efficacy?
Efficacy and safety from our point of view, from the patient's point of view, cost.
Okay. So efficacy or safety?
No, Netra, when such a philosophical question is asked, you should basically think in your mind whether you are the patient, you are going to take
What
the
would you
injection,
want?
or your father is the patient, your father is
Effective
going
or
to take the
safe?
injection. What do you want?
Effective.
Safety, efficacy, cost.
Safety.
Safety.
Good. Now, just to complete. So if you had insisted on efficacy, you know, the most effective treatment for subfoveal CNVM exudative right now, the most effective, most efficacious. One
Surgically
go,
remove
I
it.
will destroy the lesion.
Yeah,
One go, it'll never come back again.
yeah.
Right? You know that?
Macular photocoagulation.
Yes. Would you do it?
No.
Never. Because also 100% vision will go. Right? So effectiveness is not the criteria, safety is the criteria. The most important thing is safety. Now, when I consider safety for my own eye, I consider an anti-VEGF as a safer treatment than a steroid. And so I will always give myself a chance with initial anti-VEGF agents before I come to steroid. When will I come to steroid? When after, see, because I know repeated anti-VEGF agent means my risk goes up. So if after 2 or 3 injections I have not got a response, then now both the things are going against anti-VEGF, cost as well as safety. That's when I will shift to a steroid. So I will give at least 2 injections. And if with these 2 injections, I don't get a response, this means now there's a time to shift. No response, time to shift. You get a response from one of the 2 injections, time to give 1 more. Now I'm going to ask you, is there any basis, or this is just an old man giving you some conservative regime? Is there any basis for giving 3 injections in patients with diabetic macular edema before you shift? Is there any? Now, what am I asking? What I'm asking is, can 3 injections be a prognostic indicator? Is there any evidence of that?
Protocol U.
What's that?
Protocol U.
Protocol U is not to do with treatment naive treatment patients. Protocol U deals with recalcitrant patients of diabetic macular edema, and I think Gopal must be having cases on that later on.
Mm-hmm.
In patients who are treatment naive, there are the 2 most important protocols for you. One is the protocol I. Okay, and protocol I deals with ranibizumab. Okay, when they gave ranibizumab, there were 25% patients who did not need injections at month 3 or 4. They are called the elite responders. Okay, these patients need a total of around 4 injections per year, and they improve by around 2 lines. So this is a prognostic indicator. This is a therapeutic prognostic indicator. So therefore, there is a basis for saying at least give 2 injections. You'll get some idea. If in 3 you've not got an adequate response, you can shift to steroids.
And there has been a lot of other meta-analysis also, sir, which showed that the first 3 months response almost parallel the 24-month or the 36 months response.
Yeah. So this is coming. So this is old information available already. Now, is there any such thing available for aflibercept? Yes. In protocol T also, there are 48% patients who respond with more than 2-line improvement with 3 injections. So again, you can move them out. So that is why my first line, I know a lot of people differ on this also, but that is why my first line, I'm giving you the basis for saying anti-VEGFs first, and I'm giving you a basis for saying start with aflibercept if the edema is more and the vision is less, and then if you're not in those 50% of patients, you can always add Ozurdex. So that is the safest protocol to take.
Okay, unless the patient has a recent stroke, heart attack, patient cannot travel again and again to see you because anti-VEGFs require monthly injections. So those are some patients in whom you may shift to, or bilateral cases in
That's
which.
a very good point, that if you have a recent stroke or a recent MI, you need to give the patient Ozurdex. Fortunately, you have a steroids as an alternative in these patients, unlike ARMD. So you can give that. But remember one more thing also. Unless the patient has very poor vision, the patient can wait also. DA is not an emergency. This is another important point. Is there any evidence to suggest that delay of treatment of 3-4 months, 5 months will not affect the prognosis of management of DME with anti-VEGF drugs? Is there any evidence? I told you never accept without evidence. So what is the evidence? If there is an evidence, let me know. Otherwise, we have to give an emergency injection. Anybody? Do we have time for these questions? Or
Yeah, we have. It's okay, sir.
Okay.
So I think there were a lot of patients initially who were randomized into injections versus observation, or injections versus laser.
In protocol I,
trial.
Protocol I, what happened? What was the groups?
Protocol I had ranibizumab monotherapy with ranibizumab with the deferred laser, with the prompt laser, triamcinolone acetate, and laser.
The last group was what? Randomized with laser. Yeah, only laser. And what happened after 12 months? After 12 months, what did they do?
The people with the prompt laser, with the deferred laser, was having better visual acuity than with the prompt laser.
No.
The only laser.
After 12 months. What happened to the group which had got no treatment? What did they do then? After 12 months, what did they do in all three groups? They put them all on PRN treatment.
Yeah.
Okay. So what happened over the next 2 years?
Was there a catch-up improvement in vision in the patients who had laser?
Who had no injection for 12 months.
Sir, I think you should just explain that.
Okay. Now, there are two trials which are important for us to understand about how long you can defer treatment with anti-VEGFs. The first trial is the Restore. The first two trials were Restore and Protocol I. Both are similar. They had three groups. The first two groups had injections right from the beginning. The third group got no injections for the first 1 year. After 1 year, all the three groups were put on PRN treatment with ranibizumab. So what happened after 1 year? The group which had got no treatment for 1 year, that also slowly caught up. So finally, you had the ones which got injection, they went up like this, then they stayed like this. The ones which had nothing, they were like this, and now they started going up and they reached the same point. So at the end of 3 years, all the three groups ended up in the same point. Okay. Therefore, that 1 year delay did not affect the prognosis. Now, there was another study called the Rise and Ride study. There, they did not give injections for 2 years. But in this group, what happened? When they shifted over to the injections in the observation,
Third year,
they did not come back to the normal. So that means your window of opportunity is 1 year. Up to 1 year, there's no problem. Between 1 and 2 years, degenerative changes set in so that the vision does not then get improved. Is that clear now?
okay. This is in stark contrast to age-related macular degeneration. For 1 year, if you don't treat, you completely lose vision.
In 1 year, you've lost 50% of the patients have lost vision. Okay. So is that clear now? So it is not, so when I said, if the patient has a recent stroke, say patient has a recent MI 15 days back, I don't want to subject him to any stress at all. So I will tell them, okay, you come back after 4 to 6 weeks and we will treat you later on. Okay. Then when the patient comes, and in the meantime, I will start on topical treatment. After 6 weeks, if it is only diabetic macular edema, and if the vision is not too bad, it's better to wait. After 6 weeks to 8 weeks, you can start first with steroids, as Gopal was telling you. This is the group where steroids can tide you over for another 3 months. Now you've already gone 4.5 months past. After 4.5 months, if you want to add anti-VEGF, you could. Here also, let me add a rider. There is one study called the Sailor trial. Okay. The Sailor trial basically was for ARMD, and they found that in patients who have a recent stroke or a recent MI, if you give them 0.3 milligrams of ranibizumab, there is no added risk of another stroke or another MI in these patients. So if I want to give an anti-VEGF after that period, I won't start off with the full dose. I'll give them 0.3 milligrams. Now, people sometimes ask, how do you give 0.3 milligrams? See, 0.5 milligrams is in 0.05 ml. 0.3 milligram is in 0.03 ml. You don't have to change anything. It's the same drug. Instead of giving 0.05, you give 0.03 and you're safe in this group also. But we don't have this kind of result for aflibercept and bevacizumab. So keep that in mind.
Okay, so let's move on to the next case. So here is that case in which multiple anti-VEGFs were given. I had done a focal macular laser also. After that, the edema has significantly reduced and vision had improved to 6/9. This is again another case in which central leakage is there, central subfoveal detachment is there. So that's a type of OCT here. And cataract is there and vision is 6/60. Any change in strategy with the different OCT subtypes of edema like spongy, cystoid, SMD, or are there any biomarkers which OCT biomarkers or any other biomarkers which will help us decide which injection would be better in a particular patient.
What are the biomarkers in this case? Can we go back to the
KSOS junction disruption, ELM disruption, hyperreflective foci.
No, in this particular case, what are the biomarkers? This is a older OCT version, I think, which is not very clear. But I think there is a submacular detachment, which is a type of, which is an OCT pattern. Which is
detachment is there,
yeah.
right?
Yeah.
Intraretinal
cystoid edema on top of it.
Is there anything else? Is there any other biomarker available here?
Disruption of the inner retinal layers.
Can you comment on that?
No.
Hyperreflective spots.
Say that again.
Hyperreflective spots.
Okay. How would you? Which are the hyperreflective spots? How would you know whether there are hyperreflective spots or they are hard exudates? What is the difference? Can you differentiate? How will you differentiate between the two?
Is there a difference in shadowing, size?
You look at the picture. Gopal, can you show them? In there's one yellowish thing here on one side of the cyst, and you can see
that one, sir. This one
going all the way down.
This one
on the other side, and there's one here also. There's one there also.
Here.
Yeah, you were right. You were there. Yeah, there, here, and on the other side also. There are two here. You can see. Do you see what is happening? What is that black line there?
This one.
Yeah.
Backscatter from hard exudate.
Yeah, you see some. Yeah. So if it's a very small hard exudate, you could miss it. But in big hard exudates, what do you see?
Shadowing.
Yeah. So okay. So shadowing means this is not. So before you call hyperreflective spot or hyperreflective foci, you must check, are there any hard exudates in that area? If there are hard exudates, then it's not a hyperreflective foci. Only if there are no hard exudates in that particular area, then you will say that this is a hyperreflective foci. Okay. So now let's see, what are the, so you mentioned them. Now, what are the things that you can talk about them? Is there any analysis from the, I think from the Rise and Ride regarding SRF? There's a retrospective analysis available. Okay, there's a retrospective analysis which said that the patients with SRF had a better visual outcome. But that is overall okay. But it doesn't change anything. It does not mean that they don't respond to one or the other treatment. Some people will say they respond to steroids and not to anti-VEGF. That is not. Obviously, if they've got a better visual outcome with SRF in the Rise and Ride study, it means they respond to anti-VEGF also, no? So the subretinal fluid responds to both steroids and to anti-VEGF. That differentiation, if one is better than the other, is not clear. That there are contradictory reports. Okay. What about cysts?
Cysts mean that there is more chronic
factor, and large cysts are more are a poorer prognosis. Can you go back for a moment?
Yeah.
Not this one, no. It was another one.
Just get back to that. Yeah, this one.
Yeah, you see these reflective, hyperreflective spots within the cyst. These are a sign of inflammatory changes within. It's like plasmoid changes are there within. And this is chronic inflammatory changes. So this is also not a good prognostic sign for management. Large cysts are not a good sign. They are more liable to cause degeneration of the photoreceptors. In the presence of a neurosensory detachment, you cannot differentiate whether the ELM and ILM are intact.
Not possible.
Specifically, not in a stratus.
Yes.
OCT. Yeah. But if you can see the function, if that's very good, you can have a lot of edema, but if these two are intact, the visual outcome is good. This is the other thing. Hyperreflective spots, I'm just quickly answering. I think it'll take too much time if we go discussing each and so hyperreflective foci are again, these are activated microglia. So this is basically inflammatory change. They respond to both anti-VEGFs and steroids, but they found that they signify that recurrences are more common. In some studies, they've shown recurrences are more common in patients who have hyperreflective foci. Would you like to add something?
I think currently between which injection to take for which pattern of macular edema, there has not been a lot of retrospective data also on it.
Yeah.
But the personal experiences would say that cystoid macular edema may require more number of injections. Spongy edemas would respond a little faster than cystoids, and submacular detachments, definitely if it is there, we should look at hypertension, renal failure, some systemic factors like that. And they also respond quite well to anti-VEGF agents, even though ischemia is more in these patients.
Yeah, so the jury is still out. I mean, it is not something where you can these biomarkers do not predict which drug will do better.
Yeah.
But some of these biomarkers do better than others.
Yeah. So I think to end this discussion, let us basically try to summarize the clinical trials which are of importance in diabetic macular edema. The diabetic macular edema. First one is ETDRS, which defined clinically significant macular edema for us as the three criteria which Sir mentioned. And then we would do focal macular laser to the leaking microaneurysms. Number two, we may consider a focal modified grid to the areas of edema, very, very light spots, 50 micron spots, one burn width apart. That would be ETDRS. Then when we came to injections, we had the RISE and the RIDE trials initially, which basically gave us injections were much better than laser and observation. And as Sir said, even up to 1 year of observation, after that, if we started injections, they would catch up in visual acuity to the injected groups.
And the RESTORE and Protocol I trials came similar. They have the same protocols. Both of them have the same protocols, but one is driven by the company and the other is driven by the DRCR net. The Protocol I and RESTORE have similar results. And that's what showed us that 1 year delay, no problem. There is also another part to this. They found, like, if you look at this, this created a confusion that patients who had deferred laser had better visual outcomes than those who had prompt laser. But a subgroup analysis within this showed that it was those patients who had diffuse diabetic macular edema and underwent a grid probably, they had the vision loss. The patients who had focal edema and focal macular laser, they did not. Their results were identical to the results of deferred laser. Now, this is very important, but is not written in. This is in the micro print. So,
but I think this will be a little over their head, sir. Let us move on to.
There's only one point. The only one point to this is grid is not a preferred mode of treatment in today's world. Focal macular laser is good. There's no problem. Focal laser with anti-VEGF agents is the way to go. Focal laser for the areas away from the fovea and the anti-VEGF for the areas in the macula, focal in the center of the macula, center involving macula.
So translating this clinical trial into our real life situation would be like after a few injections, maybe 3 or 4 injections, you probably will require to do a fluorescent angiography and pick out the microaneurysms which are leaking and then hit them after 4 months.
This is exactly what you've done. You showed those only. And then the last thing is that if you have to decide the choice of the drug, then aflibercept is better than the other two drugs for patients who have poorer vision and higher central subfield thickness. Let me just add one more thing to this. In patients who had good vision, it was shown that the visual outcomes were identical, were similar. But actually, if you look at the central subfield thickness decrease, the macular thickness decrease, it was almost half with bevacizumab. So if the patient can't afford anything else, bevacizumab is better than giving nothing. But if the patient can afford it, then in this group also, ranibizumab and aflibercept are better drugs. One last thing, if you have patients who are very poor and whom you think can only do with bevacizumab, even in this trial they showed, if you combine the anti-VEGF treatment, whether it's bevacizumab or ranibizumab, with focal macular laser, the outcome in terms of thickness decrease is almost similar to that with aflibercept. So this is important because you must know that even for poor patients, it's not that they don't have excess. They have excess. You'll be a little more, you will use laser a little more. With the patients who are very well off, you can do with aflibercept monotherapy also. That is the difference.
And even in the protocol I, a subgroup analysis showed that the pseudophakic patients who were on triamcinolone did reasonably well. The triamcinolone arm went lower down because of the cataract that is developed.
So I think that covers most of the treatment parameters for. And of course, in patients, we've come to steroid. Ozurdex has a role in patients who do not do well within the first 2-3 injections, or those who have a problem, recent stroke, recent MI, other logistic issues, you could consider.
Now, I wanted to ask you one question. If there's a bilateral significant diabetic macular edema, would you treat one eye first with anti-VEGF and then the other eye later seeing the response, or do you treat them simultaneously, or maybe two weekly
1 weekly
injection?
At 1 week intervals. I don't give simultaneous treatments, but I would give it at 1 week intervals. The basic reason for not giving simultaneous injections is all studies have shown that the major adverse effects of anti-VEGFs occur within the first week. If you're going to get an end-off, you'll get it within the first week. So if your patient is okay by 1 week, you can go ahead and treat the other eye.
Okay, so what I may usually consider would be an anti-VEGF on the one side and Ozurdex on the other side, because there are a lot of studies which states in treatment-naive diabetic macular edema, Ozurdex also has a lot of effect. So that will reduce the number of visits and the number of injections.
I give you food for thought for you now.
Yeah.
There is a study in the eye.
Yeah, I read that.
Okay.
Yeah, with Ozurdex with anti-VEGF.
Yes.
22 letter improvement.
Naive patients, you get 20 letter improvement.
Yeah, that's a little mind-boggling. We should discuss about that later.
Yeah, so it's mind-boggling. So if you're doing this, you might as well try adding anti-VEGF on a regular basis in that patient.
Yeah.
But so, that's for this group. I for the group, this was not spoken.
Yeah, that we will discuss. So to sum up, let me tell you, choosing an anti-VEGF injection or an Ozurdex or whatever treatment for whatever disease is a little bit of a philosophical thing. So some people look at efficacy, some people look at safety, some people look at a combination, cost. A lot of things are involved in any of these decision making. And let us all agree that there are different ways to skin a cat. It's not my way, which is the highway or anything like that. There are different ways to skin the cat. And many people have, with their personal experience over a period of time, found out that their method of treatment in those situations are in those social situations, in those hospital. So the clientele, all that plays a role. So, but we have tried to speak only about evidence today, only about clinical trial evidence, which we are translating into clinical care, which may not be entirely possible in each and every patient. So to sum up, so we had the ETDRS, which we discussed. We had the DRCR protocol I, which we discussed with the 4 arms, in which the deferred laser arm with ranibizumab was really good. Then we discussed protocol T, Then we discussed protocol V, in which we had very good visual acuity patients, and we found out that in 2 years there's no significant difference between observation versus laser versus injection. Anything which you missed, sir?
Yeah, protocol U we didn't discuss much, but basically the two messages from protocol U. One message is that a lot of patients who are considered recalcitrant are actually inadequately treated. Because what happened was, when they gave patients who were being sent to them as recalcitrant macular edema, when they gave them injections, 3 consecutive injections, half of them became all right. So this is a very critical point. Those patients whom people are saying are recalcitrant, more than half of them turn out to be just inadequately treated with anti-VEGF only. And then the half which were left over, when they were treated with one group was given steroids with ranibizumab, and one was given monotherapy. Visual outcomes in the recalcitrant group of patients, both the groups got more or less similar. But remember, the thickening was much less. The decrease in the macular thickness was much more in the steroid group than in the anti-VEGF group. Incidentally, if you go through the fine print, you'll find that even the chance of getting 3-line improvement was much more in the steroid group, though the difference is only 10% versus 2%. But it's much more in the steroid group than in the monotherapy group. So the basic thing is, because these are very poor, like very bad patients, recalcitrant patients, the visual results don't get translated. The thickening does come down with steroids. Okay.
Okay, sir. Thank you very much. It was the last about 80 minutes. We had a fine discussion on diabetic macular edema. I thank all of you so much for braving Dr. Dinesh Talwar and the statistical jargon that he brings in usually. And he looks at the fine print. That's a learning experience for you. It's not just the conclusion of the trial which is important. You have to read between the lines. You look at the data which is inside, and look at the subgroup analysis which they do not present all the time, and then get a lot of insight from that, which they don't put up in the conclusions or in any body of the article they will not put. That's a very, very important learning from this particular class also. Thank you very much, sir.
You're welcome. I enjoyed myself. I'm